Morning, my name is Dave Quinn and I have prostate cancer, locally advanced prostate cancer. This is my second video blog, and the topic of this one is on treatment and my choice of treatment. So I am not saying I'm an expert in prostate cancer. I am not saying that the decisions I came to are the same that other men should come to. I'm saying that this is a decision process that I went through. I'll give you my thinking and my process and why I came to the decision that I came to. So, like a lot of you out there who have high PSA, or any of you that have been told that you have prostate cancer, my first reaction was, oh, crap. So when I went in to see the doctor in the oncology unit with my wife, that was a very frightening visit. And what he said was that the recommended treatment for me was hormone treatment and radiotherapy. Well, the first thought that jumped into my mind was, bloody hell, it's inoperable. It's so bad they can't even operate on it. So that was very frightening to me. You know, I thought, oh crikey, I'm definitely on the downward slope. Again, not necessarily true, but a common reaction. So then my next reaction was, right, I'm going to find the best surgeon I can and see if I've got a shout. So I went online and I did reading around, and I found out about the Birmingham Prostate Clinic, and I had a private appointment with a Mr. Doherty, who has a huge reputation in the field, and he's done thousands of prostatectomies. He is known as a nerve-sparing surgeon. So, you know, one of the sayings in this area is, it's not the surgery, it's the surgeon, and I think that's true. And I went and saw him, and he was a fantastic bloke, very, very helpful. And what he said basically was that he does open field prostatectomy, which is basically that don't use a robot, because a robot has a single field of vision and it can harvest a certain number of lymph nodes. Now, what it can't do is see around corners and so on like that. This is how he described it. So he did, the advantage of the robotic surgery is that you have a smaller incision and it's less traumatic. The disadvantage is it's less visual accessibility to the operating field. So Mr. Doherty told me that he preferred an open field procedure and that he would harvest up to 20 lymph nodes. The advantage of the whole process is that it stages the cancer much more accurately. You know how many of the lymph nodes have been infected, you know how far the spread is, you know how aggressive the cancer is. So that's the plus side. Now, the downside was that on my MRI scan, there's some evidence of spread into the bundle on the left-hand side, and it is likely that that would have to be cut, which would mean I'd be impotent and I'm likely to have some urinary incontinence issues. He gave me a likely cure rate of approximately 40 to 50%. So I sort of went away with Sarah thinking, well, that's better than nothing. So I booked the surgery, but Sarah, my wife, very sensibly, because I was coming from a place of fear, said, go see an oncologist. Now, there was a real delay in the NHS for me getting to see an oncologist locally. It had been nearly 3 months since my initial PSA. So I arranged to see Mr. Elmadier, an oncologist in the Birmingham Prostate Clinic. I know this sounds like a bit of an advert for them. It's not. But he was a smashing bloke, really took his time, extremely knowledgeable, and he walked us through the alternatives. So now what Mr. Doherty said, I'll go back to him briefly, he was very even-handed and very decent, and what he said was that an oncologist would probably say that there are other alternatives and to think very carefully about surgery. He also said that with my cancer, there was a likelihood of micrometastatic spread, and that it is likely that I would need to have some form of treatment thereafter. He recommended chemotherapy, but said very few oncologists would give chemotherapy after surgery. Okay, I would recommend this book by Bloom and Schultz, Invasion of the Prostate Snatchers. You know, so not being critical of the surgical approach, that is absolutely the right approach for many men, depending on their stage and their Gleason score and so on. But what it does do is it talks about where surgery sits and surgeons sit within the whole diagnostic and treatment pathway. Now, in the early days, a radical prostatectomy was the sort of best option, and surgeons like Mr. Doherty are hugely skilled, committed, and compassionate, and do the very best they can, particularly with nerve-sparing surgery. However, once a nerve bundle is cut, if he transected the nerves on the right side of my prostate, that's it. I'm not going to get an erection again. That's it, done. Viagra is not going to work in cases like that, and also likely I'll have some urinary issues. So what I do is read the pros and cons, and it goes through all the other treatment options which I shall be mentioning. Okay, so I've also mentioned this book, which is a really great book, Prostate Cancer: A New Approach to Treatment to Healing by Ripoll and Saunders, and I shall refer into that. A really, really good book. Can be a bit scary to read, particularly if you have high risk cancer like I do, but it's the real deal. I've gone and read an awful lot of papers and looked at research, including the Stampede trial. I would thoroughly recommend that you look up the Stampede trial. It is a multi-arm international trial that's been going on for some time for prostate cancer, and at the moment they've had 9,000 men take part. So really fantastic evidence-based and resource for us in terms of that. So there's loads of evidence out there. So what I'd say is, you are going to be scared. Don't jump at surgery straight away. My reaction was, I just want the thing in a bucket and gone. If it's in a bucket and gone, it can't hurt me anymore. But the dilemma is, if there's micrometastatic spread, there's micrometastatic spread, and sticking the primary tumour in a bucket is not going to make any difference to that. Okay, so in terms of the prostate cancer approach, all right, one of the really great things it does is it gives a summary table like this. It talks about low, medium, and high rate prostate cancer. It talks about the different treatments that are available. It gives the sort of percentage range of success for each one. So, for example, in my case, which is high risk prostate cancer, a radical prostatectomy, the study rates of success go from 11 to 60%. For cryotherapy, 40 to 90%. For brachytherapy, 45 to 65%. For beam radiotherapy, 21 to 43%. For IMRT, 19 to 25%. And combination, 80 to 85%. So it gives the range in the studies, some better than others. So what it does is it really genuinely gives a range of choices. The absolute take-home message, if you just look at the table there, absolutely clearly is, if you have moderate or high risk prostate cancer, having a single treatment is extremely risky. It's not to be done, all right? And actually it's not recommended. The treatment I was recommended was radiotherapy. Now, the best radiotherapy, my understanding is intensity modulated radiotherapy, IMRT, that's the evidence base. And this is a really specific targeted radiotherapy for the prostate. Okay, so the combination of IMRT and the hormone suppressing therapy, which I'm on, the Zolidex, gives a likely cure rate of about 70 to 80%. That's how I'm reading it. That's pretty darn high, and actually, in terms of, sort of the prostatectomy, it's as good a treatment, but the side effect profile is not as bad. So why did I decide not to go for surgery? All right, with high risk prostate cancer, the balance of probability is that there would have been some micrometastatic spread. Okay, so when they do a radical prostatectomy, if you imagine my hand is the prostate and my finger is the urethra, it goes from the bladder down to the penis, right? So what they have to do is cut it and then refasten, all right? So you've got all that scarring, and then you have to surgically take out the lymph nodes. So you've got all those scars. So throughout the pelvic area, there's a lot of scarring. Now, the radiotherapy that has to be done after surgery is called salvage radiotherapy. And what you're effectively then doing is you're irradiating an area that has already been damaged. So my understanding is that significantly increases the risk of side effects, right? Now, when I saw Mr. Elmadir, he said he'd seen a number of men. That's what he's an oncologist. That's what he does in the NHS. He's seen a bunch of men that had a radical prostatectomy, but years later came back with micrometastatic spread in their lymph nodes and then required salvage radiotherapy. If you're going to do radiotherapy into that area anyway, why do the surgery? The radiotherapy itself addresses the primary tumour. It disrupts its DNA. That's what works. So why then go through a surgical process that has significant side effects, irreversible side effects? So let's walk it through bit by bit. So the first thing is the testosterone suppressing medication. Now, my understanding is all men should be on that. As an intervention. Now, I have an adenocarcinoma that was identified from the biopsy, and that's, I think, the most common, and it, generally speaking, it does respond well to testosterone suppression. Prostate cancer is 5 times more sensitive to testosterone and hormone than breast cancer. So when you starve it of the testosterone, it has a really significant impact. And studies and clinical studies have shown that when the testosterone comes back, and if the tumour's there, it grows. So PSA increases, testosterone levels in the blood increase. So it's a bit of a no-brainer. Okay, so I started on the bicalutamide, which are tablets. That was just in case I had the surgery. I then went on the Zoladex. I stayed on the bicalutamide tablets for a week because when you start on the Zoladex, there is sometimes a bump in terms of testosterone, so you don't want the tumour getting fed like that, and then it drops down and your PSA should drop. Generally speaking, people get their PSA will half within the first 3 months. Now, I'm also doing a dairy-free diet, the Professor Plant's book on controlling the diet. I'll talk about in another blog. So my PSA in the first month dropped from 27 to 9. So that's a very good result. I was very happy with that. So obviously going with the hormone treatment, I will be on that for 2 to 3 years. It's a subcutaneous injection. It's a little seed that gets injected under the skin once every 3 months. Okay, truth be told, that is a painful injection. It's not like, the bloods that you get taken, which are a little prick and that's okay. That is a painful injection and there's a bit of a local bleeding. So can't say that's pleasant, can't say I'm looking forward to it, but it's necessary. So I'm going to be getting those once every 3 months for the next 2 to 3 years. Okay, so let's specifically talk about the side effects of that aspect of treatment. That's a really important treatment. For some men on the earlier Stampede trials, I think that was the only treatment they got. I spoke to a guy from Prostate Cancer UK, and he said his PSA dropped through the floor and it stayed that way, and he's been fine on the hormone treatment. So, it's a very successful, important intervention for us. So, downside. Okay, first of all, the most obvious side effect I'm experiencing are hot flushes. Now, I've got to say that it puts a wry smile on my wife's face, who also has hot flushes from her menopause. So I wouldn't say not a lot of sympathy. Of course, there's sympathy, but there's it's what goes with these sorts of things. I get them during the night. So sometimes I'm throwing the blankets off, sometimes throwing the duvet off. I now have a fan going in the corner of the room, so there's a gentle flow of air. So if I do have a hot flush, it cools me down. I also have a gel pack inside my pillowcase, and that cools my head down. All right. So those are just little things you can do, and a little fan beside the bed that will cool me down. So, what do I say? I just think every time I get a hot flush or something like that, that tells me the Zoladex is working. That's fighting the tumour. That's another one of my armies dealing with it. So that's a blessing. So, I think that's how I see it. It just shows that everything's on track and as it should be. And if it means I get some hot flushes, then so be it. Putting on weight, there's a bit of that. So really got to watch your weight. I have come up with a little slogan which I say, which is hunger is my friend, sugar is my enemy, and sugar also includes alcohol. So now there is talk about when you're on hormones like Zoladex that there is an increased risk down the line of cardiac complications. if you look into the studies and that in a little bit more detail, it's a bit more nuanced than that. Partly it's because we eat more. When we eat more, that increases the risk of type 2 diabetes, particularly as we get older. And we know with type 2 diabetes goes an increased risk of cardiac complications. All right. The other thing is that, you know, we tend to be older and there is a risk of cardiac complications anyway. And the studies are a bit equivocal about it. All right. So my sense of this is that, you know, watch your weight. If you're on the Zoladex, we'll watch our weights. All right. Watch your diet. You know, I think the Jane Plant no dairy diet is a really good one. Really watch the sugar and the snacking. And that will take care of that. It also is an anti-cancer approach on its own. So I think, okay, it's there, but don't make a big deal of it. I was looking at going on the metformin trial for Stampede, but I was randomized out of the trial. Not a bad thing because I'm already going to be taking a lot of drugs. So, but I'm definitely going to be controlling my weight through diet and lifestyle, and also regular exercise. So another one of the side effects of Zoladex can be loss of bone mass. So, you know, I'm starting my chemo in a week and a half. So regular walking, I've just come from the gym, regular exercise, doing some weights as well as cardio. So that's about, you know, sort of weight bearing exercise, and that recruits osteophytes and keeps the bone. So what I'd say is, and these are all things in our control. We can do something about it. Can't do anything about having cancer. Can do something about, you know, sort of maintaining our body weight, being sensible, being vigilant to that, and minimizing the risks. So that's the Zoladex. That's, you know, once you get the injections in, you don't have to do anything. It's just there, right? So that actually is a very easy treatment option. So the next question was about radiotherapy. Hated the idea of radiotherapy. That was what would have moved me towards surgery. But when I spoke to, just looked at the research, the intensity modulated radiotherapy, clearly an effective treatment. Concerns about damage to the bowel. The damage to the bowel occurs in about 5% of guys. All right. So I looked at that. And there is something called hydrogel, which is a pack that can go between the bowel and the prostate, so that it puts a gap, a spacer, so that means that there's less of a chance of damage to the bowel. So when I saw my oncologist, a great guy in Cheltenham, smashing bloke, Dr. Grant, he took loads of time with this. I absolutely can't speak highly enough about him. I put this to him, and he said, yeah, he'd had some guys who'd come in and had it put in. It's another surgical procedure in the area, right? So you have to consider that. And what he said was, their concern was, because the radiotherapy is every day over 7 weeks, they weren't sure whether the gel had slipped or moved. And because it's a tightly targeted intervention, their concern was the gel might have slipped and the targeting might have altered. So it's for me, it's another complication into the process. So I said, well, what do you do about the risk to the bowel? All right. And he said, we're well aware of it. It's an extremely well identified risk factor within prostate cancer and radiotherapy. So what they do is, first of all, they ask us to fill our bladders, also to empty our bowels, and we also get a phosphorus enema before every radiotherapy treatment. So it really empties the bowel out completely. And what happens is, as the bowel empties, it moves away from the prostate and minimizes the risk of damage to the bowel from the radiotherapy. So I was really encouraged by their awareness and knowledge, and they had a clear protocol for managing that. Am I looking forward to daily phosphorus enemas? No. You know, do I want my bowel to be protected? Yes. So I'll suck it up and get on with it. All right. So I've decided to go with their standard protocol. The other thing I said was, it's not just the surgery. It's the surgeon. It's not just the radiotherapy. It's the type of radiotherapy and machine and the expertise of the crew. So check all of those things out. Fortunately, in Herefordshire, you know, big up to the commissioners for Herefordshire, they've got a new linear accelerator, and I can get my IMRT in Hereford, so I don't have to travel a long way. Yay! So all of that can be done, and the crew that are manning it are the Cheltenham crew, who are very expert. So, you know, they really know their stuff. So I'm very blessed that our local service has a really good linear accelerator machine, not too far from where I live, 20-minute drive, and that the crew managing it are an expert crew. And they have a protocol for managing the risk of bowel. So I feel like that's as much as I can do in terms of managing that particular part of the process. Okay, the next important decision about treatment was chemotherapy. Now, I've mentioned the Stampede trial, and this is a big multi-arm trial, and one of the interventions they looked at was a drug called docetaxel. Now, docetaxel is a drug that's used for treating breast cancer and is very effective. It's a good drug. Now, the Stampede trial, they did a big controlled trial of this. And what they identified was both for early stage and late stage metastatic cancer, prostate cancer, it is effective. It gives, I think, about a 10% additional, cure rate. So that for me would take it up to 80-85%, which is a really big win if it works. So my logic is but the evidence is it works better for late stage metastatic cancer than the early stage. My logic is this, all right, and I checked it out with the oncologist and he agreed with it. If I'm not going to go down the surgical route, I'm treating my prostate cancer as a systemic issue, all right? So therefore, I'm going a dysregulation in my system. So therefore, I want to have interventions that are systemic. So the radiotherapy, addresses the primary tumour and the lymph nodes, although I have no lymphatic spread, thank God. And what it does is the radiotherapy disrupts the DNA in the tumour and hopefully kills it. So that addresses the tumour issue. Okay, the hormones shrink the tumour. They stop feeding it. So for some men, that might even be a cure, right? But a very significant intervention for reducing it down. So they do the shrinking down first, right? And then they do the zapping it when it's shrunk down later, all right? And that gives you your 80%-ish chance of cure. However, there may be micro metastatic spread. There's no evidence of that, but there still might be, all right? So my sense is the chemotherapy is a very powerful systemic hoover, right? It's a whole body intervention, right? And if there's any micro metastatic spread, that gives the best chance of getting it early, all right? Now, the oncologist very rightly pointed out that docetaxel has a significant side effect profile, not the least being that, so 1 in 5 men who have docetaxel will have an infection. Infection is a very serious risk when you have chemotherapy, such that they have to become an inpatient and have antibiotic treatment. Because your neutrophils, those things that fight infection, are absolutely clobbered by this drug. All right. There is a small proportion of those that go on and get septicemia and can die. So there's a risk of fatality. It's small, but it's real. It's there. All right. Particularly as it's not recommended for my stage of cancer. The other thing that was not mentioned quite so much is there is a real risk of peripheral neuropathy, so damage to the peripheral nerves, right, toes and fingers, and scalp, hair falling out. So, the question is, do I go for the docetaxel, although it wasn't it's not a treatment given locally for my stage of cancer. Bearing in mind, I'm looking at this whole thing systematically and systemically. So my argument is this. I could wait for metastatic cancer down the line, right, when I'm, say, 70 or 75, when I'm then going to be less fit and less able to tolerate the side effects of the docetaxel. I would rather have the docetaxel now when I'm 63 and fit and well, and more able to fight, the side effects, and also to catch any metastatic process as early as possible. All right. So I've decided to go for the docetaxel. I spoke to the oncologist, and even though it wasn't recommended locally, he has agreed to it. I'm getting it, and I'll be starting it in a week and a half, and I don't have to pay for it. So I'm thinking systemically at lots of different levels. So I've got my 3 treatments. I'm managing my diet. I've got exercise. I'm doing meditation. I'm doing my very best to maintain a positive mental attitude, of which this is part. So that's my treatment journey and my decisions and why I made them. Doesn't mean to say they are right for you guys. You might have very, very different choices to make. I think whatever it is, give yourself time, all right? Don't react out of fear straight away. Take a breath, talk to friends, read some books and literature, speak to your oncologist, don't just go straight for surgery, look at the different options. And whatever you go for, make sure you're happy with it. Because once you've got it in your heart, that's right for me, this is the best decision, this is what my gut is telling me is the right thing for me, having taken my time, not galloped into it. These are slow growing tumours, right? Take your time. That's going to be the best thing, right? Because then you're going to commit to it, you're going to feel good about it, you're going to feel okay about your decision. So then it's game on, rock and roll, all right? So these are the decisions I make. For me, game on. For me, rock and roll. Want to get on with the docetaxel, gonna go for it. But take your time. You know, don't jump at your decision. Look at the evidence. There is a lot out there. And if you need to, go to the Prostate Cancer UK website. Absolutely fabulous organisation, and they'll give you help and support. So good luck, brothers. Take good care. And to sisters out there who are supporting, you know, your menfolk with prostate cancer, take care of yourselves. This is a tough journey. You need support, looking after, care and love as well. For you guys out there, let your partners have a break. Let them get away from having a break from cancer. Have a holiday, have a retreat, go and see friends, have a good time. Just because we've got this, they don't have to suffer from it in the same way. So let's really support our sisters to have the best quality of life they can whilst within contact with this process. All right, good luck to you, lots of love to you. I'll be sending out loving kindness and thoughts to you all.